the fractal dimension as we approach 1. Same as in legs. Legs that were injured with a special machine called a Biodex machine. You can see the fractal dimension approaching 1 as the tissues start to try to repair itself. You get an increase in blood flow to that area, blood perfusion. That's 24 and 48 hours after injury. The injured leg and the healthy leg over here. Liver imaging, the last kind of, as in terms of tissues, liver is a fantastically complicated organ because of its dual blood supply. But can we come up with some way to evaluate the liver function with the same idea? Because the way we do things now is we take a biopsy of the liver, which is in no ways any, it's a dangerous way to do things, and there's obviously some potential complications with that. It's a focused area of the liver, so you may get healthy liver and you missed all the diseased liver. So what can we do? Okay, there's other techniques, but these involve injections. So we activated the liver by drinking a can of Ensure for lack of anything better to do. Again, it's a funny setup. If anyone's in medicine here, you may recognize it's an enema bag. We put a can of Ensure in an enema bag, and then we pulled out the little plug, and the thing poured down your throat. And, we got then liver activation. It's kind of a weird technique, but, it works, okay? It works great. Motion, again, is a problem. We use the same pattern matching algorithm. So there's a tumor right here. It's a hemangioblastoma. And no problem. I've just sped that movie up. We can track the motion, extract the data, all real-time breathing, no breath holding needed at all. And then before the Ensure and then after, you can see a whopping increase in the fractal dimension here. The liver tends to drive toward chaos as a healthy liver. The liver gets very chaotic in terms of its blood flow. Diseased liver do not exhibit this chaotic nature, which is very, very interesting. In disease, we've done lots of tumors with this as well. So here's fractal dimensions tend to go to 1 when you got really well-perfused tumors. So this is a rectal carcinoma. We published a paper on this a couple years ago. Prostate cancer, the same kind of thing. So, we're looking at blood flow into tissues without contrast agents. And then one of my students, Mohammed Warsi's, tried this with a bunch of Alzheimer's patients to see if we can look at early onset Alzheimer's. And he's just made this great movie here, cutting through the brain of an Alzheimer's patient. And then it's going to superimpose the fractal dimension on top of that brain and then compare it to a healthy age match control. So here's the Alzheimer's brain, and this is early onset Alzheimer's or suspected Alzheimer's. And then comparing it to an age match, sex match control. You can see it's a very, very clear difference in that particular ability of the brain loves to behave chaotically, and that's a healthy sign. Okay, that's very, very true in the heart, et cetera, et cetera. Okay, so to sort of sum it all up, where are we going with all this stuff? What's the big deal? We got functional tissue imaging. Okay, so that's what I've sort of this is really new stuff I've been showing here. Most people know about the brain. Okay, so I want to be able to merge complementary modalities, MRI with whatever else there's out there, to get a really detailed understanding of the disease and the disease process, not just from a structural point of view, but from a metabolic, functional point of view, because I want to be able to give the information to the physician to be able to get that active part of the disease or focus the therapy on that active part of the disease. And then using things like ultrasound to guide real-time navigation through multimodal data. That's what we're really focusing on. Ultrasound, I used to always say, ultrasound, who can figure that out? But I've come to really love ultrasound. I bought an ultrasound machine, and now it's like, I love this thing. It's real time. We can now co-register with a lot of other modalities, and really you can use the ultrasound because it's all real time stuff, and you can do your intervention or therapy in real time, which is really, really nice. And that therapy may be guided, may be focused x-rays, it may be putting in a biopsy needle or whatever you have, okay? It's really, really a great technique to have as a complementary modality. Okay, so just to show a few pictures of where things are in terms of in my lab with these multimodal techniques, I have, as Dr. Anvari said, I've done a lot of work with Sentinel Medical in Toronto, and they've done a lot of development of their breast imaging system. We've got 2 of these at St. Joe's. One of them is under development all the time for 3 Tesla, and one of them we use as a workhorse in our clinical magnet. And in this particular case, it's breast imaging. The woman goes in feet first, and you have these little grid patterns here. So when you get the information about the tumor, you can put a biopsy needle in, and you've got access to the breast laterally and medially as well if you need it. You can put a biopsy gun in there, use vacuum-assisted biopsy like one of these devices by Hologic, and you can take out whatever part of the tumor and then put the woman back and forth in the magnet, back and forth all the time to, did we get the biopsy or we didn't? So in they go, out they come, in they go. So it's a lot of in and out of the magnet. That's the only bit of a disadvantage. And they've got some nice software that registers the needle going in and tracking it to where the tumor might be. But this is not done in real time. This is all done, as I said, you do the imaging, they come out, you put a guide little, like a device in, you put them back in, you bring them back out, you put the biopsy thing in, you put them, so it's a lot of this and that. So not real time. And it's also using an expensive technology, MRI. So as an alternative, add other sources of imaging information to then go outside of that expensive environment. So here's an example. We have a PET-CT at St. Joe's as well, and this is an example of some PET-CT data scaling from the CT side, which is high-resolution anatomic data, putting down the metabolic information data where the yellow hotspots are metabolically active parts of the tumor. So that's one modality we can then bring in as another source of information to provide to a multimodal platform, metabolic information. This is information about perfusion. So here's a prostate tumor, and the tumor is right here. And this is I think I got a little. I don't know if I click here. Yes. Okay. So there's the. Okay. There's a bit of motion in there, but we've corrected for it. But there's the tumor right there with an elevated perfusion. So that's another thing we can bring in. So I showed you that osteosarcoma earlier. We can also bring in other sources of magnetic resonance imaging data. So one of my students, Ali Reza Akbari, made a sodium imaging coil. With MRI, we're not just restricted to doing stuff with hydrogen, which is how MRIs, all the clinical MRIs are based around hydrogen or water. We can image other nuclei as well for free. Okay, we just got to build the hardware, which is no problem in my lab. So this coil here is sensitive to sodium. Sodium-23 is the native kind of sodium in your body. It's not radioactive. You don't have to inject anything. It's just straight up sodium. So this is a sodium image through the leg. So that we know that from various diseases, sodium will actually increase in concentration. We're working on right now looking at intra versus extracellular sodium and measuring those things as well. So we can bring that in. We can do phosphorus imaging as well. So if you want to look at ATP levels or other things like that, other metabolites of other nuclei in the body, that's quite easy to do with MRI. I won't say it's easy for a clinical magnet because clinical magnets, they just don't have the support or the people around that could build the hardware to do this kind of thing. But it's certainly the realm of the possible. And then also within the realm of the possible is doing metabolic imaging. And a great example is with prostates, where if you have a metabolic image superimposed on a prostate image, high red here is high choline, and normally the prostate has a lot of citric acid in it. And in the case of cancer, you'll see a real skewing ratio between a high choline to citrate ratio, and we know that that's indicative of an aggressive kind of tumor. So this is another metabolic data set that you can then bring into a multimodal imaging system. Also on the MRI side, we can bring diffusion tensor imaging in. So this is from a paper we published about 5 years ago where we're looking at the fibers in the leg. Okay, this was done in the leg. I did it in the leg because everybody else had done it in the brain, and I thought, oh, well, let's try the leg because there's fibers there too. In the brain, we can look at where tumors will erode into the fibers or where they push the fibers aside. In the leg, we can look at these as well. This is the bipinnate nature of the gastrocnemius right here in the lower leg. That's the tibia right here and the fibula. Nice parallel lines of these fibers. They're just randomly colorized for no apparent reason, just colorized so you can see them. Okay, and then if we look at the other leg here, let's see here, where it's more of a tear in the muscle. You can see it. The muscle's all beat up right here. It's all been shredded. Someone hobbled in. This was someone that runs to Brantford every day. So from Hamilton. Okay, I said, well, maybe no, don't do that.